So let's first just talk briefly about who we are. I'm going to go over this very quickly, but I just want you to understand what our expertise is, the time that we've been in this industry, and why we're qualified to talk about this particular topic. Carroll Harper and Associates is what's called a managing general agency in the Medicare business, founded back in 1975 by my mentor and partner, Carroll Harper. So we certainly are the oldest Medicare general agency in the state of Maine. I began with Carroll. I started in 1988. Carter is the newest member of our management squad. He's a young guy in the office starting in 2021. The three of us manage over 40 independent Medicare advisors around the state of Maine. So these folks may be under a different name than ours. It might be Cross Insurance or Clark Insurance, or we have many, but we provide them the training, the guidance, the oversight, and assistance with their customer. We're managing over 12,000 individuals' Medicare benefits in the state of Maine. So we certainly do a lot of that. We have three offices in Maine, Portland, Maine, Bangor, Maine, Southwest Harbor, Maine. We also have a lot of referral arrangements or partnerships, if you will, with different employer groups. We do this for a lot of the larger employers in the state to help with their retirees, their employees, and their customers. And I'm going to skip over this, but I just want you to be able to visually see who the three managers are. Carroll Harper, he's the founder of our company, still works every day. Myself, started in 1988. And then the third member of our management team is Carter. So the three of us, along with all of our staff people, run the organization, and our brokers are independent. So some of this is going to be for people that are getting ready for Medicare. Other pieces of this are going to be for people that are already covered by Medicare. So a couple quick questions. How does one become eligible for Medicare? Two ways. You're eligible for Medicare when you become 65 years of age. So don't be confused thinking because your full retirement age for Social Security benefits might be 66 or 67, Medicare still starts at age 65. So you're entitled to Medicare when you become age 65, or if somebody is receiving Social Security disability payments for a period of 24 months, they will automatically be enrolled in Medicare as a result of that disability. How does the enrollment for Medicare work? If somebody is new to Medicare and they're already collecting a Social Security check, let's say they started at 65 or perhaps even early at 62, they will automatically be enrolled in Medicare. They're not going to have to do anything. They're just going to open their mail one day and there will be a red, white, and blue Medicare card waiting for them. If people are receiving Social Security disability payments for a period of 24 months, on the 25th month, they're going to receive a Medicare card in the mail. So those folks, the enrollment is quite simple. If you're not collecting a Social Security or disability payment, then you must be proactive. They're not going to notify you and tell you, oh, it's time to sign up for Medicare. You have to be proactive and know that it's time to do that. So people usually start that process 3 months prior to the month in which you qualify. Is enrollment in Medicare a requirement? No, it's not a requirement. People are not forced to be in Medicare. It's an optional program. Nobody is forced to enroll in the Medicare program. Most people are going to, and they paid money towards this program, so they certainly want to get the value and get the benefit of it. A lot of folks continue to work past age 65. If you're employed by an employer that has more than 20 enrolled employees, you can defer Medicare Part B and stay covered under that employer-sponsored group insurance plan. So the key here is the size of the company that you work for. If it's greater than 20 employees, you can use the group insurance as your primary coverage and defer enrolling in Medicare Part B. Generally, people will enroll in Medicare Part A when they're 65. That's the piece that you prepay for. There's no recurring premium for it. So generally, people will do that. But there are situations where you might want to defer both Part A and Part B. And we'll talk specifically about that. Here's one of those situations. Health savings account. Often employers now, their group insurance plans are health savings compatible. What that does is that allows you as an employee or a participant in that group insurance plan to have a compatible medical insurance that you can use with a health savings account. And you can put money into that health savings account to use for unreimbursed medical, dental, vision care expenses. But there are some very, very specific rules regarding Medicare. If you are enrolled in any part of Medicare, Part A, Part B, Part C, Part D, you cannot fund a health savings account. Very, very important. If you're enrolled in any part of Medicare, you cannot continue to fund a health savings account. So if somebody is covered by a group insurance plan and it's health savings compatible and they want to continue to fund that account, they would not want to be enrolled in any part of Medicare. Defer it all, and you can do that as long as it's creditable coverage. Now, another tricky thing that happens related to health savings accounts is when you ultimately decide to enroll in Medicare. Let's assume for a minute that I wait until I'm 67 years of age, and now I decide I'm going to retire and I want to enroll in Medicare. They're going to backdate my Part A coverage 6 months. Everybody asks me, why do they do this, Jay? I don't know the answer. There's some things that our government does that I don't know that anybody can truly explain why it makes sense, but they do this. They backdate your Part A by 6 months. They'll never go back beyond when you turn 65. So it's 6 months or to the date in which you turn 65. So remember, you have to stop funding the health savings account at least 6 months in advance of when you ultimately want to elect Medicare if it's beyond age 65. You can continue to use the monies in your health savings account to pay for unreimbursed expenses, and you can even use the health savings dollars to pay Medicare Part B premiums if you're not yet collecting your Social Security. Medicare and COBRA. A lot of times employees will say to us, well, I'm retiring from my job. I'm covered by a group insurance plan. I like the plan. I think I'm going to elect COBRA and not enroll in Medicare. That's not a good decision. So the way that it works, the government does not consider COBRA, even though it's the same exact coverage that you might have had as an active employee. They do not consider COBRA to be creditable coverage. So it's like you've had a lapse in coverage, which ultimately will mean you incur a penalty when you ultimately get to signing up for Medicare. We always tell folks, do not elect COBRA if you're Medicare eligible, okay? Good rule of thumb, do not elect COBRA, okay? If you're under 65, that's perfectly fine. But if you're over 65 and eligible for Medicare, you need to enroll in Medicare. Do not elect COBRA. Okay, so now we're going to get into the nuts and bolts. So once you enroll with Medicare, and Part A and Part B is administered by the Centers for Medicare Service, everybody has to do that enrollment either online or through an appointment with the Social Security office. Medicare contracts the Social Security Administration to process enrollments and also to collect the premiums on their behalf. Once you've done that, everybody has to decide how they want to receive their Medicare benefits. There are two distinct ways people can get their Medicare coverages. Now, number one, or option one, you add to your original Medicare program, the red, white, and blue card that you all receive from Medicare. You can add what's called a Medicare supplement plan. Some people also refer to these as Medigap or companion plans. They all mean the same thing. These are designed to work with your red, white, and blue card. And they're really to fill in the void. So the deductibles and the co-pays and the co-insurances that are within Medicare Part A and B, supplemental plans can pay those so that you don't have to as a consumer. When you choose this path, you also have to enroll in a separate prescription drug plan. We refer to these as standalone Part D prescription drug programs. Now, both the supplemental plans and the Part D plans are administered by insurance companies. So you're going to process these enrollments directly with a particular insurance company and receive a card for each of these plans. The second way that people can now get their Medicare coverage is they can enroll in what's called Medicare Part C. This is what we all know as Medicare Advantage plans. You see them advertised constantly. These are plans that will combine the Part A, the Part B, and the drug coverage, wrap it all together in one plan. So you get one card from an insurance company, and that's the only card that you carry with you. You don't use the original Medicare card, you don't have a separate supplement, and you don't have a separate drug plan. So I wanted to show this slide to give you context as we start to dive into the different parts of Medicare. So let's begin by talking about the red, white, and blue card that's issued by the Centers for Medicare Service. This card, when you receive it and you ultimately decide to go down the path of Medicare, it has Part A, hospital, Part B, medical. Now, keep in mind, these are not terribly descriptive of what they actually do, but this program has been around since 1965. So things have certainly evolved since the program was started. What Medicare Part A is designed to help us with as consumers is if we're admitted to a hospital, if we are admitted to a medical rehabilitation facility, some refer to that as skilled nursing care, if we are receiving any type of hospice care and certain home health care services. Those are the four big components under Medicare Part A. Now, Part A has out-of-pocket cost. So that's why you don't find many people that just carry around a red, white, and blue Medicare card because they don't want to face the out-of-pocket that's included with Medicare. So let's talk about a few examples. And these are all 2025 numbers. Out-of-pocket expense if you're admitted to the hospital, $1,676 is the deductible for Medicare Part A. So if you're admitted to the hospital, you're going to be responsible for $1,676 unless you have another insurance to cover that for you. So that deductible is per benefit period, which is from 1 day to 60 days. So it doesn't matter if you're in for a night, a week, or a month, it's a $1,676 deductible. Where it does matter is if you leave that hospital and you're away from it for more than 60 days and go back in, it's a new benefit period, therefore another deductible. So that can happen more than once in the same year. God forbid somebody is in the hospital continuously beyond 60 days, then they start to accrue a per day coinsurance amount. For 2025, that amount is $419 per day. So people are very thankful to have supplemental plans at that point. That goes from day 61 to 90. At day 91, that number doubles. It goes to $838 per day, beginning on day 91 through day 150. Medicare only covers 150 continuous days. So if somebody's in a acute bed for 150 days, Medicare is going to stop paying after that. Supplemental plans will pick up additional days beyond that. Days 91 through 150 are what they refer to as lifetime reserve days. That means that we as consumers can only access those days once in our lifetime through Medicare. If we need those days a second or a third time, it's the responsibility of supplemental insurance, not of the federal government's Medicare program. Skilled nursing, this is medical rehabilitation, much trickier. There's some rules that we think are quite dated. Well, we don't think, we know they're dated, but Medicare is an old program. Skilled nursing, in order to qualify to go to a medical rehab facility, the rule says you must first be hospitalized on an admitted basis for 3 nights. So you have to be overnight in the hospital on an admitted status for 3 nights to qualify to go to medical rehab. That, at some point in time, likely made sense, but today people are getting knees and hips. They're doing that and going home the same day or the next day. They're not going to meet that 3-night requirement. So it's a little more difficult. Hospitals sort of muddied the waters when they started keeping their patients on observation status. That's difficult. Observation status is not the same as admitted. So there's some complexities to getting to a skilled bed. Once you're there, Medicare allows 100 days per benefit period. They cover the first 20 of these days in full. The back 80 days have a co-payment amount of $209.50 per day. Now, all of these out-of-pocket costs that I've talked about here, these can all be paid by a Medicare supplement plan. So I don't want people to be panicked thinking, oh gosh, I've got to face all these out-of-pocket costs. They're in the Medicare program, but that's why people buy. Now, Medicare Part B, this on the red, white, and blue card says medical next to it. This is all of the physician charges. So Part A is only facility. It's not the medical doctors that treat you when you're in a facility. It's not you seeing your doctors in their own offices. This is what Part B is designed to do. All of your outpatient services, if you're getting an X-ray or an MRI or labs, things like durable medical equipment, if you needed a CPAP machine or a nebulizer or a wheelchair, these are all Part B expenses. Couple of lesser known things that are covered under Part B, what they refer to as Part B drugs. Part B drugs are drugs that are administered through infusion therapy. These are not drugs that you go to your local pharmacy and pick up. They're drugs that you're going to get infused at a facility, such as chemotherapy or Remicade for arthritis. These are covered under the medical, not the drug benefit. Now, Part B is what we call a pay-as-you-go program. So Medicare Part A is what we all pay payroll taxes towards during our working years. And as long as you qualify for a Social Security benefit or have a spouse that does, meaning you've worked at least 40 quarters, you'll get Medicare Part A at no recurring premium. But Medicare Part B is a pay-as-you-go program. You've never paid anything towards this during your working years. You start paying a premium when you sign up and begin using the coverage. The government is going to determine the premium necessary to support the trust annually. So Medicare Part B premiums, once you start, they're not etched in stone. They will change over time. So for 2025, consumers are obligated to pay $185 per month for Medicare Part B. That's what they call the standard monthly premium. To put that into context for people that are maybe high wage earners into their retirement years, if a married couple has adjusted gross income that exceeds $212,000, their premium might be higher. Okay, and it goes up categorically through $750,000 or greater in adjusted gross income. So the government has a standard premium, which does apply to more than 90% of American retirees, but some people will pay more than the standard premium. Now, how does Medicare Part B work? What's the cost share look like? There's a calendar year deductible. That deductible is $257 for the calendar year of 2025. After that, there's a 20% coinsurance. So in other words, Medicare is going to pay 80% of the bills, leaving a 20% responsibility for us as consumers or for a supplemental insurance plan if we choose to enroll in. Now, Medicare Part C, these are the Medicare Advantage plans. These are private health plans that maintain a contract with the Centers for Medicare Service. Now, the whole concept behind Medicare Advantage when it first started was maybe the government should be doing more than just adjudicating claims. Maybe they should be in the business of helping retirees stay well. Maybe there should be an option that includes wellness programs and nurse case managers and chronic disease control and all those things. So when they decided to go down this path, and this all became a reality December the 8th of 2003, when President Bush signed the Medicare Modernization Act, that laid the groundwork for Part C and Part D of Medicare. So these are contractual relationships between the government and insurance companies. The contracts say that these plans must cover all of the same services that are covered by Medicare Part A and Part B. They're not allowed to exclude Medicare covered services. These plans are allowed to go beyond the scope of Medicare. So you see the advertisements. They're talking about buying golf memberships and hearing aids and dental and eyeglasses. Those are not Medicare covered benefits. The insurance plans can cover additional items beyond the scope of Medicare, but Medicare has to sign off on their benefits every single year. So these are annual renewable contracts between the government and insurance companies. The government pays the insurance company every month to administer your Medicare benefits. So when you see these plans being advertised at zero premium, obviously they're getting paid. They're getting paid by the government, not directly from the consumer. They're federally subsidized and are for calendar year contracts. All Medicare Advantage plans are required to have what they refer to as a maximum out of pocket. So consumers know when they purchase a plan that they can never spend more than a certain dollar amount. Medicare Advantage plans are not available in all counties. The plan benefits and the pricing differs between counties. Now, I could do a whole presentation on why that is, but very quickly, Medicare loss ratio is county specific across the country. That impacts what providers that operate in each county are paid. The health of a county it's an easy way to think of that. Not all counties are the same. Population and medical competition. You know, how many hospitals are in the area? Are there multiple choices as to where consumers can go to get care? The more competition, the lower the pricing is, and that's reflected in insurance premiums and benefits. So just to give you an example of the number of these plans that might be out there, in Cumberland County in 2025, there are 6 insurance companies offering Medicare Advantage plans, but there are a total number of plans being offered of 28. So there's a lot of choices. Medicare Advantage plans are very similar to group insurance in the standpoint that they're either going to be PPOs, HMOs, HMO point of service. All this simply has to do with, is there a network of contracted providers? Are you obligated to stay in the network, or can you go outside of it? Some plans have national networks, so it encompasses all 50 states. So there's some complexities there. Medicare Advantage plans, I talked about this already, are allowed to cover additional things. Some examples: dental, vision, hearing, fitness, over-the-counter medication, hands-on physicals, foreign emergency travel. Plans are calendar year. Medicare must approve the benefits every year. So Medicare Advantage plans, people frequently ask, well, how can I change these coverages? And am I limited? Can I only choose this option once? There's a lot of confusion about this. Maine is unique. We live in a great state. In the state of Maine, if people choose to enroll in a Medicare Advantage plan, we have 36 months under Maine law to try out a Medicare Advantage plan. And if we choose to go back to original Medicare, it's guaranteed. We can go back to original Medicare, buy a supplement and a drug plan, and they cannot say no. That's different nationally. So a lot of the information that you read or sessions that you sit in on about Medicare, they're going to say, oh no, you got to be careful. You can only have 1 year. That's true in other states, but not in Maine. We have 36 months. You can change Medicare Advantage plans to other Medicare Advantage plans at different intervals. So we have the annual enrollment period, which is October 15th through December 7th. You have the open enrollment period, which is January 1st through the last day of March. These are opportunities for you to change up your coverage in those plans. So I want to talk specifically about a piece of legislation, and this is really critical for all of you that are already enrolled in Medicare. It was signed into law in August of 2022 by the Biden administration. It was called the Inflation Reduction Act. This included significant mandates for Medicare Part D prescription drug coverage. So it started back in January of 2023 when they mandated that all insurance plans in the Medicare prescription drug space participate in the Senior Saver Insulin program. That already existed. It was created under a prior administration, but it wasn't a mandate. Now it is. So insulin costs are capped at $35. January of 2024, they said anyone that gets to the catastrophic coverage phase of Medicare Part D will not have any cost share for the balance of the year. We're just about through 2024, so I'm not going to belabor that. The big changes are all happening January 1 of 2025. We have what's called the removal of, the elimination of the donut hole, the coverage gap that's been inside Medicare prescription drug plans since the fall of 2006 when they were first rolled out to the public. Which always had a donut hole or a coverage gap. That's gone for 2025. Enormous change. They've implemented a lower maximum out-of-pocket amount for consumers, what they can spend out of pocket for Part D. New prescription payment plan, and I'll talk about each one of these things. So the removal of the coverage gap, this was a big one. So now, starting January 1 of next year, Medicare prescription drug coverage will include 3 phases. We have what's called the deductible phase or the deductible stage. Plans can have deductibles if they choose to, up to a maximum established by Medicare of $590 annually. Typically, if a plan includes a deductible, it's only going to be on the brand name drugs. This is not 100% across the board factual with all plans, but in general, most plans are only going to have a deductible on the expensive tiered medications, not on the day-to-day generic. Phase 2 is called the initial coverage stage. This is where we all go to the pharmacy, pick up our medication, And we are responsible for paying either a co-payment or a co-insurance. So we either pay a flat dollar amount for the medication or perhaps a percentage of the cost of the medication. The third phase is what they call catastrophic coverage. Third phase used to be the donut hole. So they've eliminated that. The way it's going to work in 2025 is if a consumer pays out of pocket, and this includes two things. It includes what we pay when we go to the pharmacy, but any amount that's paid by others on our behalf also counts towards this $2,000. So this is a worst case scenario now for prescription drugs. Once somebody hits that benchmark of $2,000, they're covered 100% for the balance of the year for all of their medications. This is a really significant change. The out-of-pocket maximum of $2,000. When they talk about others on our behalf, what the government is doing is they're looking at what we actually pay at the pharmacy, but they're also looking at the total drug cost, and they take 25% of that. If that is more than what we actually physically paid at the pharmacy, they count the higher amount towards the $2,000. So a lot of consumers in 2025 won't spend anywhere near $2,000, but they're going to hit that threshold. So this is a really welcome change for a lot of consumers. Just to contrast that, in 2024, the maximum out of pocket was $8,000. Now that includes what we as consumers paid, plus some money from the drug manufacturers themselves, but still, it's a drastic reduction. New for 2025, they've rolled out this thing known as a prescription payment plan. You can't talk to your insurance broker about this. The insurance companies are not going to really publicize this very much in print. It's something that you have to call the pharmacy benefit manager and request. What this is designed to do, if it's a financial hardship for a consumer to have all of this front loaded, so maybe they have a big deductible and the way their drugs are structured, they have to pay a lot early in the year, and they cannot afford to do that. They can request from the pharmacy benefit manager that they pay the pharmacy on your behalf, and you will enter into a payment agreement to spread that over the 12 months. So if you're a plan, if you happen to be on outrageously expensive medications and it said you have to pay $2,000 in January and nothing for the rest of the year, you could request that they take that $2,000 and spread that over 12 months. There's no interest. It's going to be a big help to a lot of folks. So that's new for 2025. All right, so I know we're getting short on time, but I want to talk about Medicare supplement plans, Medigap plans. So Medicare supplement plans are standardized plans. What does that mean for us as consumers? It means if we buy a supplement in the state of Maine, they're lettered from A to N. There are 10 plans and they're standardized. So if we buy a plan F or a plan G, it doesn't matter if we buy that from AARP or Anthem Blue Cross or Humana or Aetna, the coverage is identical. It's standardized coverage. The only thing it differs from one plan to another is going to be the price. Okay, so some insurance companies can operate more efficiently than others and will offer their products at a lower premium. This is true in 47 states. We had 3 states that opted out of the standardization back when the government first took this on. They still had to standardize their plans, but they're not offering the 10 that the government created. So the most popular Medicare supplement plan for a very long time was what we all called a Plan F, as in Frank. So prior to January 1 of 2020, that was the norm. That's what most people purchased. Now it's Plan N as in Nancy and G as in George that we see as the most popular options among consumers. So to give you a really quick overview, Plan F is 100% coverage. So Plan F covered all of the Medicare Part A and Part B deductibles, co-pays, co-insurances. So a consumer had no out-of-pocket between Medicare and a Plan F. Plan G covers everything except for the Part B deductible. So this year that was $240 for the calendar year. Next year it's increasing to $257. So that's all a consumer would pay out of pocket for Medicare eligible. A Plan N requires that we as consumers not only pay that Part B deductible ourselves, but in addition to that, we're going to have to pay copays for services. $20 office copay and $50 for emergency and urgent care. So obviously, because we're paying more out of our pocket throughout the year, the cost of that policy will be low. Massachusetts, Minnesota, and Wisconsin are the 3 states that didn't adopt the 10 standardized plans. Massachusetts has 3. Minnesota has 3, but they also have riders. So they did similar things. Couple of other key things. Plans C and F are no longer available if you're new to Medicare after January 1 of 2020. The Affordable Care Act had a provision called MACRA that said nobody in the United States can own 100% medical coverage after that date. So people that had Plan F and Plan C, which were 100% coverage, could keep them. They were grandfathered, but nobody new after that date to Medicare were allowed to purchase the plan. Supplements are guaranteed renewable for life. The only time you're ever going to lose a supplement is if you stop paying. Otherwise, you will be able to keep that policy for life. Supplements don't cover a lot of things. Supplements don't pay for routine annual physical exams. They cover a wellness checkup instead. They don't cover dental and vision and hearing and fitness and those things. So when you see those things talked about, it's Medicare Advantage. Now, one thing, again, this is the state of Maine, and this, we can all thank the founder of our company, Carol Harper, for these wonderful things because he's a tireless advocate in Augusta. He designed what is known now in Maine as Rule Chapter 275. This is a piece of legislation that he felt really, he was compelled to do this because insurance companies were coming into Maine, small marketplace, offering a great rate on a supplemental plan, and 12 months later, the rate went through the roof and people didn't qualify to change because of their medical history. Rule Chapter 275 addressed that problem. So in the state of Maine, you can change your Medicare supplement plan to a like or lesser plan at will. You don't have to do it during enrollment period. So if you have a Medicare supplement plan G with Blue Cross Blue Shield, and you find out that AARP offers a plan G at a significant cost savings, you can change to that plan at any time. The only time they can ask you medical questions and possibly decline you is if you're trying to go to a better plan. If you're going to a like or lesser plan, that is protected and guaranteed under Rule Chapter 275. So an enormous, enormous benefit that we have in Maine that other states do not have. So quickly, I'll just mention our process, how we work with individuals and how that process works. Obviously, we have an initial discussion with people to learn about their situation. Are they already in Medicare? Are they retiring? Are they looking for us to help them determine if their group insurance is better? Is Medicare better? All these different things that come into our office on a daily basis. So that initial discussion is really critical for us to lay out expectations and a timeline of how we might be of assistance. We help people with all of their enrollment forms. We explain to them how to get signed up for Medicare if they haven't done that yet. We assist them through that process. If they need employment verification forms, we walk through that with them. We do an education session where we dive into education, show people different options as to how they can get their Medicare coverage, because it's not a one shoe fits all, certainly. It's based on an individual's medical needs, their providers, their medications, whether they're living in 2 parts of our country or staying in Maine year round. All those things impact the decision. When they ultimately get ready, we'll assist them with enrolling in plans. And then we become that service person after that. So our office services all of these folks, regardless of what they're enrolled in for a Medicare health plan. And we help them through the process of evaluating on an annual basis. I know that was a lot of information. I talk fast, I apologize, but I didn't want to shortchange people. I think this is a super important topic. There's a lot of changes. 2025 is a big year of change. For anyone that's enrolled in Medicare already, this is not the year to assume that you can just leave your coverage alone. Plans change drastically for 2025 as a result of this Inflation Reduction Act. So you want to revisit, make sure your plan is still the right fit for the upcoming year.
We have just one in here so far that I haven't answered already. It's a question about the excess charges under Medicare Part B and why Plan N doesn't cover them or what they are.
So what excess charges are related to? If a medical provider wants to bill in excess of the Medicare reimbursable amount in the state of Maine, providers are allowed legally to bill in excess, but that can never exceed 15% of the charge. We do not see that in the state of Maine. I can't speak to every state in the United States, but I can tell you the number of times in my career, and I've been at this much longer than most, the number of times I've seen a provider bill in excess of what they receive from Medicare, I could count them on one hand. So I wouldn't discourage somebody if they feel like a Plan N is the appropriate choice for them. I would not discourage them from buying that plan with the idea that they're going to get billed excess charge. We just don't see that as being a big.
If somebody is like looking ahead next year, they're turning 65 sometime next year. When do you want to start the process? I know you talked about the 6 month thing with HSAs and all, but yep. I mean, what's a good time frame to get started?
3 months.
3 months.
What I would recommend if your birthday is in April, your Medicare coverage will always begin the first of the month in which you turn 65, unless your birthday happens to fall on the 1st, then they actually move it back a month. So if your birthday is on April 1st, your Medicare coverage will actually start March 1st. But any other day during the month, it will start the 1st of that month. Mm-hmm. We recommend start this process 3 months prior to the month that you turn 65. That'll give you an appropriate amount of time to be educated, to look at plan options, and also to get the process of signing up for Medicare Part A and Part B completed, because that's done by the government. It's done by the Social Security Administration. So we can't control that time frame. There are times during the year when that might take a bit longer than others.
Mm-hmm.
That's a fair time
if
frame.
You're not taking Social Security,
mm-hmm.
the Medicare premium, you'll be deducting that from your checking account, if you will.
You can set that up. Initially, what the government will do, again, they contract the Social Security Administration to collect the money. So they will invoice you. And then the initial invoice will actually be for 3 months. It'll be a quarterly invoice. And when folks receive that initial invoice, it's going to say right in the body of that, if you want to set up a monthly auto pay out of your checking account or go online and use a credit card to pay, there's different ways you can do it.
Mhm.
Some people will just choose to pay the quarterly payment and do it that way. That's how that works.
Mhm. So if you're just, not taking Social Security till later and still working full time, you're just paying for
They'll
like
bill
your
you. Yep, they
insurance.
bill you for it. And later on, when you sign up and start taking a Social Security check, they're automatically gonna deduct that amount out of your monthly Social
Mhm.
Security.
I just turned 65, but will be working at a good job with a large employer for another 1.5 years. After that, I might continue on my life insurance since she works for the state. I just need to sign up for Part A, correct? How do I defer Part B?
Okay, so the bottom line there is, as long as you're covered by a large employer and your health insurance plan is not a HSA compatible plan, then yes, I would recommend that you enroll in Medicare Part A. There's no downside to that. You've already paid for it. And obviously that will make the process later on of signing up for Part B easier. So the process that you'll use is you can either go on the computer onto the SSA.gov, the Social Security site. If you have a My Social Security account established, you can elect to just enroll in Part A and defer Part B. And you can do all that electronically on their site. If you don't want to do that, you can contact the Social Security Administration. They will schedule an appointment. It'll be a phone appointment. And they'll reach out to you at a certain date and time, and you can let them know, I want to enroll in Part A only. I would wish to defer Part B. So that's how that process would work.
What is the profile of a person who would be better off on the standard Medicare plan versus Part C? What type of health profile would favor an Advantage plan? Fairly specific, personalized question, but you likely can speak a bit in
Yeah,
generalities about it.
in general, supplement plans in original Medicare versus Medicare Advantage, they're both a legitimate way to get your Medicare coverage. They both have strengths and weaknesses. I think in general, if I was to give an example of who might really benefit from having traditional Medicare and a supplement, somebody that's going through routine cancer care, somebody that's going through chemotherapy and radiation. It might be financially more attractive for that individual to have original Medicare with a supplement. Even though the supplements are expensive, they might be better off to pay that premium versus dealing with the potential out-of-pocket expense in a Medicare Advantage. Ideally, people that choose Medicare Advantage plans are people that generally are fairly healthy, don't have an unreasonable amount of utilization, like the extra benefits that are included in those plans. Another scenario that I often use when I talk about these, I look at a original Medicare with a supplement and a drug plan. I sometimes refer to that as prepaying for your care, because you're going to pay a large monthly premium to the insurance company for the supplement. But if you have a terrible medical situation, you got a minimal amount of out-of-pocket expense. So it's like you're prepaying for your care by paying that higher monthly premium cost. Advantage plans are more like paying as you go. So you're not going to pay any monthly premium in most scenarios, but you're going to have to pay co-pays along the way when you access care. So there is a point where one will be clearly better than the other. And that's why we have that initial consultation, is to figure out what people are using for care and do our best to forecast what might work for you on every slide. So if you have questions, if you want to bounce stuff off us, or we can be of help to any of you, reach out anytime. We're always happy to answer questions and to guide people as best we can. So if you need us, reach out to us.